Do you have like a university hospital there, or is it like private?
All right, so today is your last Basecamp lecture. We're talking about GI bleeds. My name's Cassandra. I'm your chief here at the VA. For those of you watching online, we'll mute everybody in the room when there's time for discussion, so you can also think on your own. Let's get started. So GI bleeds are some of my favorite patients to admit because you can admit 5 different GI bleed patients in a night, and you can have 5 different clinical courses and 5 different outcomes. And GI bleed patients are some of the most unpredictable. They can be totally stable, and within 10 minutes, you're pushing someone down the hallway to the MICU because they are getting sick. So my objectives for you is that by the end of this talk, I want you to be able to construct a framework for GI bleed management, to be able to diagnose hemorrhagic shock, to choose appropriate blood product transfusion, and then to differentiate between GI bleed management in cirrhotic and non-cirrhotic patients. Questions on any of this? Okay, let's jump in. So take some time with your partners at your table and just spitball all of the different places and problems that could cause a GI bleed in an inpatient or outpatient. So take about a minute, and then we'll come back as a big group and talk through it. Let's come back together. So I'll try and take 2 from each table. Just shout out places that could bleed in the GI tract.
Esophagus.
Yep, great. And like, what's the problem in those places that could cause the bleed?
Varices.
Perfect, esophageal varices. Agnes, what about in the duodenum? What could happen? Yeah, an ulcer. Other thoughts here from table 1?
Diverticulosis.
Yeah, a diverticular bleed. Perfect. Any other thoughts?
Hemorrhoids.
Hemorrhoids. Love it. So don't forget about your oropharynx. Epistaxis can commonly be mistaken for GI bleeding. In our upper GI tract, we have things like Mallory-Weiss tears, varices, peptic ulcer disease, portal hypertensive gastropathy, gastritis. For our lower GI bleeds, we have things like a diverticular bleed, AVMs, if someone has malignancy, a fistula from a prior surgery that's causing a bleed, or any sort of inflammatory bowel disease. Yeah?
Sorry, could you just portal hypertensive gastropathy?
We'll chat about it during the course of this month here together. But basically, it's just a buildup of pressure that causes the capillaries in the stomach to leak. All right, so now that we've talked about what can bleed, we have to talk about how it will manifest in our patients. And so this is not meant to be a trick at all. Let's go through it as a big group. If someone is having hematemesis, then where is their bleed, upper or lower? Great. If they're having coffee ground emesis, upper or lower? So it's going to be upper, and what kind of an upper GI bleed? Fast, slow? Yes, because the blood has time to be digested before they vomit it up. Melena, so dark black stool, upper or lower? I'm seeing upper, I'm seeing both. You guys are right. So if it's a very proximal lower GI bleed, then the blood can be digested before it comes out. Typically common with an upper GI bleed. And what about hematochezia? So bright red blood coming out of their rectum. So I'm hearing lower or either. What kind? Brisk upper. Sorry, I revealed before you guys said it. But yeah, so usually a lower GI bleed, but then if they're having a brisk upper GI bleed, it could also just come out bright red. Questions on this? Okay. So let's jump into our cases. We're pretending like you guys are some swing residents that are on admitting patients here at the VA. You have these 2 patients that the ER doctor calls to you, and then they're busy, they gotta go run off and see someone else. So you're not gonna get more information from them aside from this. Our first guy is a 45-year-old male. He has a history of AFib. He's on anticoagulation. He also has a history of diverticulosis, and he's coming in with dark maroon stool for the last day. Says he's been drinking a 6-pack and a pint of vodka a day to deal with his depression regarding the pandemic. And then we have a 50-year-old female She has a history of cirrhosis and esophageal varices. She's coming in with 3 days of black stool, and she's a little bit tired for the ER doctor. So you get the sign out on these two patients. That's what they tell you. They have some labs cooking for both of them. What's going to help you make your decision in terms of who to go see first?
Vital signs?
Yeah, how stable they are, their vital signs. Labs are still cooking, so we don't have those yet. But yes, perfect. So you're going to look at their vitals. And so any thoughts on which patient you'd want to go see first based on these vital signs that you have?
Number 2.
Patient number 2. Great. And then what's motivating you to say that? Yeah, so they're tacky, their blood pressure's a little bit lower. And then what else about her picture would make you want to see her first? She's symptomatic, she's tired, and she is a cirrhotic patient who's bleeding. The other guy has no history of cirrhosis as far as we know. So you always see the cirrhotic patient first, just because they can change so quickly. Unless the other patient is in like frank hemorrhagic shock, then obviously go see the person who has more disturbed vital signs first. Okay, so you go and chat with her, here are her vital signs. The ER doctor has some labs that are cooking for you, just basic labs. What are things that you're going to pay attention to on vital sign or on your physical exam to help you deduce maybe what could be happening with this patient's bleed? What are you going to look for on her physical exam to help you figure out what could be going on in terms of her bleed?
Is she bleeding? Like, you see, like, she bleeding or somewhere?
Perfect. Yeah. So your power of observation as a doctor is critical. If you walk into the room and there's blood all over the floor and her gown is covered in blood, like that tells you a lot versus if there's not a drop of blood in the room. So you're going to just look and see what she looks like. Gabby?
I don't know if this is jumping too far ahead, but maybe like look at her skin and see if there's like a TPA or any type of anything else that could be like coagulation.
Perfect. Yeah, so she has liver disease. So she have evidence of coagulopathy on exam. What's the most important thing you guys are going to do on your physical exam? I see Megan doing something with her finger. Yeah, so you have to do a rectal exam on these patients. No matter what somebody else tells you, it is your responsibility. You are now the doctor taking care of them. You have to just get over it. Find the lube, find the gloves, do the exam.
I'm fine to do that, but I did read a study that's actually pretty low sensitivity. So if it's still something I would do.
Still something that you should do because when you call GI and you can say, I visualize myself that bright red blood is pouring out of this person's rectum, or like, I visualize myself there is melena on the exam, that means something to your consultants versus saying like, I don't know, the ER doctor maybe saw something, but I'm not really sure, I didn't do an exam. So, great. So you go to see her. She is somnolent, but she awakens to voice. She's got no bleeding anywhere in her mouth, nothing on her gown. She's oriented. She has no asterixis. She's tachycardic. She's warm and she has distal pulses. And then on her rectal exam, you see some melena, but it's mostly brown stool. On her exam, there's no frank blood. And then let's take a peek at her labs. So her BMP is just notable for a creatinine of 1.8. Her CBC has a hemoglobin of 9. And platelets of 70 with an INR of 2. I'll tell you that her baseline hemoglobin in the chart was 9.5, so she's not that far off from her last check. Any thoughts or concerns about this? Okay.
Going back to the sensitivity comment too, I think that's super helpful. And just to remember that sensitivity means that if a person has it, what is the probability that it's going to be positive? So not having it totally does not rule out the GI bleeding person. But then I wonder, like, what's the specificity? The specificity is if a person doesn't have GI bleeding, what is the chance they won't have blood in their stool? And so in this case, I would be curious if it's like highly, like what the specificity is too. So just like, I love when people bring up epi and just like really hone in on like what that means. So they can just hearing that.
Dr. Mayer dropping some knowledge about sensitivity and specificity. So overall, are you guys concerned about this patient? Does she fall into your sick, not sick categorization? Where would you put her? Okay, so people are saying sick. Second years, what would you say? Sick. Okay. She's pretty stable though overall, right? Like she's not massively bleeding anywhere. She does have cirrhosis and varices, so it's something to be aware of. But at this moment, you know, she's a watcher, I'd say, but she's not someone I'm rushing off to the ICU. Okay, So we're going to go through the exercise of admitting this patient, and in doing so, we'll be building our framework for how we should think about GI bleed patients. So the first thing that I want you to think about with your partner is what sort of access are you going to ask for in this patient? What sort of transfusion goals do you have? What monitoring do you want the nurse to do? What labs are you going to get and how often? What are you going to think about for her med rec? Do we have to do anything different to manage her because she's cirrhotic? And then what is our final intervention going to be for her? So take about 2 minutes, talk with your partner, and then we'll sort of go through each of the pairs and just answer each of the questions. So we'll start with Irvin here and then just work our way across the room. Okay? Take it away.
Like access?
So the first thing we have to think about is access. If this patient needed blood, how are we going to actually put it from the bag into her body? So Irvin, what are you thinking about?
Putting in 2 large bore IVs. So we're saying 16 to 18 gauge.
Okay, perfect. I think the phrase that we often learn is 2 large bore IVs, but then nobody ever figures out what number that means. So 16 gauge or greater. Perfect. And the reason why we want a 16 gauge IV is Poiseuille's law. So you want something that's short and fat, because the longer something is and the narrower it is, the more resistance there is for that fluid to pass through. So that's why we focus so much on something that's short and fat. So on the left side, you have your IV catheters. You want a 16 gauge or greater. When we say or greater, we mean the diameter is greater, which means the number in front of it is actually smaller. So a 22 gauge is really small. A 14 is huge. Does anybody know what that thing is on the red background? What kind of catheter that is?
Bone marrow, I forget the name of it.
So close. That one is actually the intraosseous, or IO, is the third picture. That little like drill that's held up to someone's leg. The one on the red background is a Hone catheter. And so that's like a big, really fat catheter that you can put in the ICU if somebody needs a lot of blood quickly. The IO can be used as a primary infusion site. It has to be in the humeral head instead of the tibia. And then the last one is your triple lumen that your ICU patients have. If you have a patient who's in the ICU who has a GI bleed and it's the only line that they have, is that an appropriate transfusion line? No. Seeing lots of heads, shaking no. Why?
Too long.
It's too up.
It's too long.
Too long and too narrow. So in that bottom right corner, you can see that if you have a triple lumen catheter, the diameters of the actual lumens is very small. So you have 3 tubes running through that one encased tube for your triple lumen. And then it's also super long, 20 centimeters or longer. So that's not something that you can transfuse through. Questions about this? Okay. Transfusion goals. Did you two talk about what you would be monitoring for and what you transfuse to?
Yeah, we said transfuse for a hemoglobin less than 7.
Perfect.
Symptomatic.
Okay, love it. Any other things that you think about with transfusions?
We also briefly talked about platelets.
Yeah.
Said platelets under 10.
Okay.
We're discussing.
Yeah, 10 is a number that comes up. Anybody have any other thoughts about platelet transfusion thresholds?
So 10 said they're not actively bleeding, because the risk of spontaneous bleeding is a range, but they're actively bleeding and use the transfusion rule 50.
Yep, perfect. So Dr. Mayer's hitting the nail on the head. So hemoglobin, if it's less than 7, you should transfuse them. Their platelets, if it's less than 50 and they're bleeding, we're going to transfuse them. If it's less than 10, you transfuse to prevent spontaneous bleeding. The other threshold that you'll hear about is 75 or 100, and that's for intracranial bleeding. So neurosurgery will tell you what their goal is in case you hear that. Any other things that you think about transfusing to?
Well, they don't have symptoms and then hemoglobin less than 7, perhaps you don't transfuse.
Perfect. Yeah. So if their hemoglobin is greater than 7 and they're not symptomatic, you don't transfuse. But I'm talking about maybe other lab parameters. So their INR. Most places, if someone's actively bleeding, if their INR is greater than 2, you want to transfuse to fix that. We'll talk about what to give. And then also fibrinogen. So if a patient is in DIC, most places will use less than 150 as a cutoff, but it can vary depending on your attending and your institution. So just talk to them to see what their threshold is. Questions about this? Anybody know why we picked 7 as a transfusion strategy? That's what?
Nothing.
So a good number, a round number, or a nice number. So we actually have some data. This New England Journal study had a restrictive versus liberal transfusion strategy. The restrictive was that they only transfused patients with upper GI bleeds who were less than 7. The liberal was those patients who were bleeding, as long as their hemoglobin was less than 9, they would transfuse them. And so you can see on the left-hand side of the Kaplan-Meier curve, looking at overall survival, that black line is much higher. That's the restrictive strategy compared to the liberal strategy. And then also you can look at the hazard ratios there in that plot and see that for almost all types of patients, the restrictive strategy was better. So we do have data to say why we do what we do. Now you can tell people next time, we're like, why'd you pick 7? You're like, oh, I have a study that I can show you. Okay. Something that you might hear about, not necessarily here at the VA, but if you're at Denver Health or you're at the university, there's a lab called a TEG or a thromboelastogram. Has anybody ever heard of that? Okay, so mostly our second years. So a TEG is another way to look at platelet function. And if you want, you can actually take a picture of this portion at the bottom. So sometimes your ICU attendings or your attendings where this test is available will say that you can transfuse someone based off their TEG numbers. And it's very different from your actual like CBC. They talk about like a maximum amplitude and like a K time. So I just have a picture of this in my phone that I refer to. We can talk more about TEGs at another time, but just wanted you to know about it in case someone brings it up. Also, fun fact, Ernest Moore is a surgeon over at Denver Health. The ER is named after him, I believe. Hunter is one of his sons, who's a surgery fellow, or surgery resident. And then Peter Moore is his son, who's a pulmonary fellow here. So you guys will run into the Moores throughout your time here at CU. Okay, monitoring. You two, what are you going to ask your nurse to do to monitor the patient while they're here?
Frequent vital signs, we're thinking even faster than Q4 if possible, checking with the nurse if that's even possible.
Okay, so vital signs, maybe Q4. What else can you ask for?
They're there.
Yeah, so like neuro exams. What's something that the nurse can put on the patient to maybe do more frequent monitoring for you? Yes, great. So vital sign frequency, Q4 hours is what I would do for any patient who is coming in with a bleed. You can space it out if they show they're stable over time. This is also not the patient where you say it's okay for no vital signs overnight. Like you want their vitals because it's going to tell you if you need to be concerned about their bleeding. And then telemetry. Why do we order telemetry? Do you guys remember from Dr. King's shock talk about why tele is important?
Tachycardia is going to be the first sign of the hypoblemia from blood loss.
Great. So remember that cardiac output is stroke volume times heart rate. If somebody is bleeding, their stroke volume is going to go down because they have less preload. Therefore, if stroke volume goes down, heart rate has to go up, and tachycardia will be the first sign that somebody's having a more significant bleed. Labs. Kyle, what did you guys talk about? What do you want to check?
We talked about CBC, Q6 hours. You can get PTO, we already know this one's.
Yep.
I think that's about it. You can check, like, I don't think you need to be checking BMP more frequently than once a day.
Yeah.
See if renal function is affected.
Okay, and then what's one more test you maybe want to get on admission?
Type and the right one.
Yes.
I don't know if it's screen or cross or.
Great. Put the type and screen. So type and screen will take the patient's blood and say what blood do they have, like A positive, O negative. A type and cross means that they take an extra step and they say, here are 2 bags of blood or 1 bag of blood that we can save for you and send up as needed. So yes, every patient, even if their hemoglobin is stable, it's above 7, you still want to get that type and screen because you want to have that information in case they start bleeding. CBCs should be Q4 max. If you're thinking of checking any sooner, that patient should be in the ICU and not on the floor. And then your coags, check them daily. If it applies to your patient, maybe twice a day if there's someone who's in DIC or something else, but at least once a day, or at least once on admission. Questions about this? Okay.
Not this, but with the vital signs.
Yeah.
Would you ever want to go faster than Q4?
If you are checking vital signs more frequently than Q4 because they're abnormal, then that patient needs to be in step down or DIC. All right, so MedRex. Nico, what sort of stuff did your group talk about? What are things that we would consider holding in patients that are admitted with a GI bleed?
Anything that makes you bleed.
Anything that makes you bleed, love it. Any other thoughts? Other things that we could hold?
Like and the diuretics?
Yeah, so diuretics. What are things along those lines? So we're going to hold anything that will make us bleed. We're going to hold diuretics. GVT prophylaxis. Karen, did you say something? Yeah, beta blockers. Okay, great. So you want to hold any blood pressure medication because if someone becomes hypotensive, you need to know if it's from their meds or from their bleed. You're holding beta blockers, diuretics. I'd also say if somebody's on a lot of centrally acting medications, you may want to hold some of those when they come in because if they're altered, is that a sign of shock or is that just that they took too much oxycodone? You don't know if you have both of those going on. And then for your anticoagulants and your antiplatelets, obviously we want to hold those if we can, but if your patient just had a stent placed 3 days ago or had a PE diagnosed last week they were in the ICU for, obviously it's a more nuanced situation. You have to talk about the risks and benefits of either holding or continuing those medications in your clinical scenario. What sorts of medications should we reverse if someone's actively bleeding, they have a life-threatening bleed? Yeah, so any anticoagulant, right? So if someone's on warfarin, you can give them some vitamin K, you can give them FFP, you can give them PCC. If someone is on like dabigatran or Pixaban, we have reversal agents for those, but they're very expensive. And so it truly has to be a life-threatening bleed that we can't keep up with in terms of transfusion. So let's look at her medication list. Who wants to continue spironolactone? Her furosemide, her propranolol, and then what about her lactulose? Seeing maybe, maybe not. So I would actually continue her lactulose because you want to make sure that if she becomes confused, it's not due to her maybe underlying HE. And it's okay to continue lactulose. It's not going to make them bleed more if they're already bleeding. So that's something that I would keep on. All right, let's see where we are. Gabby, I think we're at your group. Any thoughts around managing a bleed in a cirrhotic patient? It's okay if the answer is no. We can phone a friend.
Thoughts that
Yeah.
it's different and harder.
It is different. Anybody else have any thoughts? Want to help Gabby out?
Isn't there more of an indication to use octreotide in a cirrhotic?
Yeah.
Part of it, especially
Yep.
if it's a very slow bleed.
Perfect. That's point number 3. What are 2 other things that we can do? And if they had ascites, what would that make us want to do?
SBP.
Yes, so SBP, we have to think about infection. Okay, let's jump in. Later on, if you guys want, if you scan that little image, it'll take you to a Word document with all of the papers that are on this slide. So when I admit a GI bleeder who's also cirrhotic, I have 3 principles that I think about. I think about reducing the acid, reducing the rates of infection, and reducing their portal pressure. So acid reduction, when a clot forms, it is harder for it to form and stay stable in an acidic environment. So what are some medications we could give to reduce acid in a patient? Great. So you're going to give this patient 80 milligrams of IV pantoprazole times 1 for a bolus, and then 40 IV BID. And this actually goes for any patient with an upper GI bleed, not just cirrhotics. So you want to stabilize that clot that's forming in their, their duodenum, their stomach, wherever it is. And the reason why we do it, we have randomized controlled trials that say that patients who receive a PPI are less likely to rebleed compared to those who don't. There is no mortality benefit to giving the PPI, but there is a reduction in rebleeding. Second thing, reducing the rates of infection. So I heard some people talking about ascites, maybe SBP. And so we're going to give these patients ceftriaxone, 1 gram once daily for 7 days. And it actually helps prevent not just SBP, but any other infections. So SBP is usually the one that we think of, but cirrhotics are functionally immunosuppressed. And so they get pneumonia, they get UTIs, they get other problems too when they're in the hospital. And that's why we prophylax them with ceftriaxone. In the past, we used to give quinolones, but now we have data that shows that ceftriaxone is better due to quinolone resistance. This one does have a mortality benefit. So there is less mortality in patients who receive ceftriaxone who are cirrhotics coming in with bleeds. And then reducing the portal pressure. So I love it. Mentioning octreotide, you're going to give them a 50 mic bolus, and then you're going to give them an infusion at 50 mics per hour. You keep it on for 2 to 3 days or until GI tells you it's okay to stop it sooner. And so that helps to reduce the amount of portal pressure. And so if we reduce the portal pressure, there's a chance it could reduce the pressure in the varices and the patient will not bleed. Again, it helps decrease rates of rebleeding, but there's no mortality benefit for octreotide either.
So you just put it on empirically.
Mm-hmm. And then again, we have papers that say why we do that. Questions on this? It's a big slide.
Wouldn't reducing the acid be beneficial in anybody?
Yep, yeah. So any patient who comes in with an upper GI bleed, you want to give them a PPI, but especially in cirrhotics.
Okay.
You don't want to forget it. Okay, great questions. All right, so let's move on to writing our note. We put in all those orders. The lady is now on the floor. She's doing well. The nurse knows about everything. And you're getting ready to type out your note. And so we have our 50-year-old with cirrhosis. We have to come up with a summary statement for her. And so here's a little formula for you. You want to talk about the demographic characteristics, what they're presenting with over what time course, concerning for whatever your diagnosis is. So any brave soul that wants to take a crack at coming up with a summary statement for her?
She the one that wanted Pixabay?
That was the first guy. So she's on just normal, furosemides, spironolactone, beta blocker, lactulose.
50-year-old female, relevant with a past medical history of cirrhosis, taking the meds that were just mentioned, who presents with fatigue and dark brown stool over the past week, 3 days, concerning for possible GI bleed with a differential including upper GI bleed versus an alternative source.
Great. Here was my proposed one. I put in that she has cirrhosis and known varices because that is always important to know if you have a cirrhotic who's bleeding. She's coming in with new onset melena, concerning for an upper GI bleed, currently hemodynamically stable. Questions on that? These are flexible, so as long as it includes the pertinent past medical history and medications, you can put whatever you want into it. So you're getting work done, you're writing your note, you're getting ready to go see that second patient, the guy who is on apixaban, waiting in the ER. You're beginning his admission when you get this page. So what does that mean to you when you get a star 911? Yeah, do you like finish drinking your coffee? We're like, I'm gonna finish my note and then I'll go see this patient.
No,
What do you do?
run.
Run in slow motion down the hall.
Okay, run in slow motion down the hall like a movie to your patient's room. Great. That is the correct answer. So if a nurse is paging 911, that means that they need help. So as you're running over, she's calling you and she's like, here are your patient's vitals. She's now tachy to 120. Her blood pressure is 70/40. You walk into the room and she's awake but not responsive, and she has active hematemesis now. So she's throwing up everywhere, bright red blood. She's cold. She's not really responsive. What are your thoughts now about her clinical situation?
Sick.
Yeah, she is sick now. And then what are you concerned about in this patient? Yes, so an esophageal varice that's bleeding. Okay, but what's our new diagnosis? Think back to your talk with Dr. King. Yes, hemorrhagic shock, love it. What labs are you guys gonna order in this moment? CBC, lactate. Great, all appropriate. And then what are you gonna do to differently manage her now? Give her blood, love that answer. Are you gonna just like leave her in her normal room? No. Transfer her to the ICU. So would you call a code in this situation?
Call a rapid, get more help.
There you go, call a rapid. So code is for like someone is dead and like they have no pulse, you have to come into the room. But calling a rapid response will get you lots of help. Love it.
Question, how do I call rapid?
You can just tell the nurse to call a rapid. Yeah. Okay, let's jump in. So we repeated some labs. Her hemoglobin is now 5.7. The rest of her labs are pretty much the same. Her creatinine's a little bit worse. She's got a little bit of an LFT injury. Her lactate is 5. So things are clearly worse than before.
I just have a quick question. I don't know what the protocol is for this hospital or if it's all hospitals are the same, but does the ED like type and cross as soon as they get there? Or like are we ready to give her units? Like if
That's a good question. So the ER will sometimes send a type and screen, sometimes not. If they're hemodynamically unstable in the ER, then they'll transfuse them, or if they have an anemia in the ER, they'll start giving them blood. But like for her, when she arrived, she had no requirement for a transfusion, so they wouldn't have like saved blood for her.
so when in this process should we be starting that so like it's ready while we're
Yeah, so if they come in and their admission CBC does not require a transfusion or their hemodynamics don't require it, it's okay to do a type and screen,
okay.
and then we'll know what kind of blood they need. We can get that up.
Okay, got it.
Okay, so now I want to ask you guys, what if on her repeat CBC, so her admission hemoglobin was 9, what if it was 8.5? Would you still say we can hold off on giving her blood? No, seeing some no's, why? Yeah, she's symptomatic, she's in hemorrhagic shock. So just to reiterate, if you took a machete to my left arm and you drew blood from my right at the same time, my hemoglobin would probably be totally normal, but you would still want to transfuse me because clinically I'm actively losing blood. So do not be fooled by your labs if your patient is bleeding in front of you. You just need to give them product.
And also, can you get the CBC back and it cannot drop yet because it's acute?
Yep, that is entirely accurate. So don't be fooled by your labs, okay? All right, and so our diagnosis, we talked about that. She has an esophageal varix bleed. She's in hemorrhagic shock. And then there are a couple things that we can do to change our management to help stabilize her. So we're gonna give her fluid. Ideally, we're gonna give her blood, like Gabby mentioned. But if the blood bank's gonna take like 40 minutes to send up a bag and you have normal saline in the room, give her the normal saline because she's gonna get more damage from her hypovolemic state than she is from reduced oxygen carrying capacity. So she needs some sort of product. Again, ideally blood, but we'll roll with what we got. Let's say we gave her a liter of fluid in the room and her blood pressure was not responding and she's still actively vomiting. What's something that we can ask the blood bank to do? Have you ever had to use something special from the blood bank, Lila? Yes, so you can initiate the massive transfusion protocol. So that means that the blood bank has this cooler of blood that's O negative. There's like cryo and platelets also that come up, and they just send up the cooler and they keep sending blood until you don't need it anymore. So, but you have to call them. You can't just put in the order because it's a big resource. So you're going to initiate the massive transfusion protocol for this patient because she's not responding to product. We're going to upgrade her to the ICU, like you guys mentioned. We're going to get some more help. We're going to trend her lab, so checking CBCs, BMPs, making sure there's no evidence of end organ damage. You're going to call GI, right? Because what are they gonna do to help stop this process? Yes, so they're gonna try and go in there and band. Okay, let's talk
That's a
about,
quick question
yeah.
just about that.
Mhm.
If you're trying to, just like maybe logistically, if you're trying to transfer somebody like this to the ICU and the ICU is full, like, do you just bring that stuff into that room or like what's the protocol?
yeah, so there will always be a bed.
Okay.
You know, even if the, like at the university, if the NICU is full, there are
Mhm.
other ICUs that the patients can go to.
And they can just like, they'll
Yep.
just physically transport
Yeah.
them there.
But I've had patients who are in hemorrhagic shock and you're wheeling them down the hall and a nurse is squeezing a
Okay.
bag of blood and things are
So
happening as
things
they're
are still
moving.
happening as you're moving them, because I
Yeah.
feel like that's a big use of time. to
Yep.
get them somewhere. Okay.
Yeah, and you should be taking steps to enact everything, even if they're not physically moved over to the ICU, yeah. Great question. Okay, so let's correct her coagulopathy. This is not meant to be a trick in the beginning. For her hemoglobin of 7.5, what are you gonna give her? Great. For her platelets, they're 30K, she's actively bleeding, so we're gonna transfuse her, what? Okay. Her INR is 3. What's something that we could give her to help bring that down? FFP or vitamin K. 2 answers there. Then her fibrinogen is less than 150. What are we going to give her? Great.
Is the vitamin K, does that take longer than the FFP to correct the INR? Or do you have one preference over the other?
So if someone is sick like this, you'd give them both. If they're stable and their INR is high, like 5, 6, and you're worried about them bleeding with that INR, you can give them some vitamin K without giving them the FFP. But for somebody who's sick in hemorrhagic shock, you throw it all at them. All right. So now that she's in the ICU, we have to actually call GI, right, to come and see her. So anybody want to take a crack at calling her consult?
No.
I'll be your GI fellow, so I'll be very nice to you guys.
I'll give it a shot.
Okay, great.
Ring, ring, ring.
Hi, this is Cassandra with GI.
Hi, this is Connor from internal medicine. I have a consult for you, a unstable GI bleed.
Okay, great. What have you done for them?
So we have, do you want to hear more about them or you want to hear?
I
about
do,
them?
yes, I'd love to hear more about them.
She is a something age woman with a history of cirrhosis and known esophageal varices, coming in with what seems like an upper GI bleed. Hemoglobin tanked from 9 to 5 point something. Blood pressure went down to like 90 over 50. We have given her some units of blood. We've given her some FFP.
Great, sounds like I need to come see this person.
Yeah, so it looks like you need to see them, yeah.
Great,
Got
That's what you
access.
said.
I'll be there.
Thank you.
Yeah, so calling a consult, you want to make sure that they know this is a GI bleed and a cirrhotic. You want to give them their medical record number or their room number here at the VA. And then for her, the important things are to say she has no esophageal varices, she's in hemorrhagic shock, the massive transfusion protocol has been initiated, she's moving to the ICU, I've started her on octreotide, a PPI and ceftriaxone, she's NPO. When can you come see her? Not can you come see her, when can I expect to see you? Okay.
Question? Just a quick question for the slide about the transfusion stuff. Why would you just give whole blood? Like, you know, like she has like, I'm just wondering like when you give PRBC versus whole blood.
Yeah, so I think at most places you'll be giving the components of the whole blood,
Okay.
and it'll just depend on their coagulopathy and what they need.
Okay. So you don't usually just give whole blood, you just give the components.
Yeah, but great question. Okay, so GI knows about her and they're coming to see her. She's moved to the ICU. The massive transfusion protocol is going. She's intubated for airway protection because she's having all this hematemesis. And GI calls you back and says, hey, I'm really sorry. I'm over at Denver Health. I have another patient who's bleeding. So can you like hold on for another hour or so? And that might be a call that you get because they're covering multiple hospitals. And so what are some things that you guys can do with your pulmonary colleagues to help temporize her bleeding? Love it. You go hit the nail on the head. So it's called a Minnesota or a Blakemore tube. It's a rubber catheter that you can insert in and then balloon up, and then you put traction against the balloon so that way it rises up and puts pressure against the varices. If you guys need to place one of these, your pulmonary fellow will be the one who's likely doing it. So don't feel like, oh, you got to figure out how to do this on your own. Yes, Gabby.
Sorry, I have so many questions.
No, it's okay.
At what point would you need to intubate your patient if they're like actively throwing out blood?
So if they're somnolent, if they can't protect their airway,
Okay.
they need to be intubated. Okay, And then let's say that you tried the Minnesota tube, but it's not quite working. What's another service that you can call for a procedure to help out with GI bleeding in a cirrhotic? Yeah, what are they gonna do?
Tips.
Great. So TIPS, they basically go in there, they put a stent in to bypass the portal system to reduce the pressure. And so, if GI can't scope them for some reason, IR is usually in-house, they can get there pretty quickly. They can do a TIPS. What's a contraindication to TIPS? Yeah, so if somebody has really bad hepatic encephalopathy, it'll only get worse after the TIPS because now you're bypassing the liver completely with their toxins in their blood. But again, it's like a risk-benefit scenario. If someone's going to die from their esophageal bleed, you need to just figure out the risks and benefits and talk about it with the family.
Can you D-tips them later?
No. Yeah, once it's in, it's in. They can downsize it, but
Are these interventions considered emergency interventions, or do we need to get like consent for each and every one of these things?
if family is there, it's always good to talk to them and ask them. But if someone, if the patient is unconscious and can't consent, you have no family contacts, you just do what you have to do. Okay, great question. So, great job, guys. Your patient gets scoped, her varices are banded, she's discharged 2 days later on her PO antibiotics to finish her 7-day course of ceftriaxone. Again, do not forget that she has to finish out that 7-day course. So please do give them an equivalent PO alternative. We did some time travel to get to the end of her clinical course, but let's go back to that night. We're the Sping resident. So in our last couple minutes, you have this other guy, he's 45, AFib on anticoagulation, history of diverticulosis, coming in with dark maroon stool for a day. His vitals, we had said, were stable. So what are your thoughts about what sort of bleed this guy could have? Yep, so if he had an upper GI bleed, it would have to be what kind of upper GI bleed? Brisk. And then what would his vital signs do if he was having a brisk upper GI bleed? It'd probably be abnormal, right? So it's probably not an upper GI bleed. What else could it be?
Because small intestine, or like not like end of the colon, but kind of in between.
So it could be a lower GI bleed. What about his history is going to clue you in about a possible source? Yeah, history of diverticulosis. So maybe he has a diverticular bleed, and that's why he's coming in. So talked about that. He's admitted. We have his labs. Anything on his labs alarming to you guys? Remember, he's been drinking, but he has no known history of cirrhosis. Do we have to worry about those cirrhotic interventions for him?
Truthfully, I don't have the fish bone memorized for the liver labs.
Yeah, great point. So the top line from left to right, protein, albumin, total bilirubin, direct bilirubin, AST, ALT, and then alk phos at the bottom. But anything here raising your suspicion for cirrhosis? No. So what would you be looking for on his labs?
For cirrhosis?
Well,
yeah, I would be looking at that top one.
Yeah, great. You guys got it. So low albumin, reduced synthetic function of the liver. So his albumin might be low, his platelets might be low, he might be coagulopathic. We don't see any of that on his lab, and he has no known history of cirrhosis, so we don't have to go into that whole cirrhotic intervention.
Low sodium.
Low sodium too, if you're volume overloaded. Okay, so we did all of our things in our little algorithm. We admitted him, we asked for a 16 gauge IV in both arms. We're transfusing him if his hemoglobin's less than 7. We have him on tele, and we're checking his vitals Q4, checking his CBC every 8 hours. We're holding his apixaban because you guys are on top of it. You're like, I'm going to give him a bowel regimen to help prep him for GI to do a colonoscopy. No history of cirrhosis, so we don't need any empiric antibiotics or octreotide. We're not concerned about an upper GI bleed, so we're not going to give him that PPI to reduce the acid. He's NPO. And then you call GI and said, hey, I got a guy here with a lower GI bleed. Can you scope him tomorrow? They say, sure. Questions on this? Okay. So the next day, his hemoglobin and vitals are stable in the morning. GI is aware. They say, we'll probably get to him in the afternoon. We have a couple other urgent cases. But during the afternoon, he has profound hematochezia. He's hypotensive and tachycardic, but his vitals are responsive to IV fluids. So you're going to call GI to give them an update. And what are you going to ask for now?
The typing cross.
You're gonna ask GI for that?
Oh, no, okay.
So you were worried about it possibly being what kind of bleed when he first came in?
Cool.
Yeah, so an upper bleed. So now he's having hematochezia, that's profound and it's affecting his vitals. So what do we have to rule out? A brisk upper bleed, perfect. So GI is gonna scope the patient sooner than they would have. They do an EGD first, it's normal. So remember, any patient who's hemodynamically unstable with a lower GI bleed should first rule out a brisk upper bleed. They go in and they do the colonoscopy. This is what they see. What's that? Yeah, so they say diverticular bleed. They go in there, they inject some epi, it stops. Hip hip hooray. He's saved. But what happens if they injected and then 8 hours later after his colonoscopy, he just starts bleeding again? Or what if they went in there and they couldn't see anything that was bleeding, which is very possible? What are some other options that we have to help manage a lower GI bleed that is refractory?
Tap blood cell to find out where it is. Embolize.
Yeah, so we can maybe embolize something that's bleeding. Who else could we call?
Can't you do like a imaging that like highlights bleeds?
Yeah, so that scan can help tell you where a bleed might be happening. What if it's like really bad? The patient is here for days. They will not stop bleeding from their diverticula. They've required multiple transfusions. GI has scoped them 100 times and has found nothing. Yes. So the first people you're going to call for lower GI bleeds is GI. They can do things like do a colonoscopy, do some intervention. They can do cautery. They can inject different medications. They can clip them. Sometimes though that just doesn't work. So they can't find the bleed or the patient bleeds through that. In which case you can talk to IR, you can talk about getting a CTA, tagged red blood cell scan, and then embolizing something. But if they can't embolize that vessel that's bleeding and the patient is still bleeding, your last resort is to call colorectal surgery for a colectomy. I've had to do this once for a patient in residency, a Jehovah's Witness who was admitted with a lower GI bleed. And so he didn't want any blood product. GI tried to scope him a bunch of times to find the bleed, couldn't find it, couldn't embolize the vessel. And so ultimately he went to the OR to have his colon removed, and he did really well afterwards, but that is obviously an extreme situation. But good for you guys to know your if-thens, so you know who to call if things aren't improving. Questions on this? Okay, all right, we got through a lot today. So we created a framework for GI bleed admissions. We talked about access, transfusion goals, monitoring, labs, having a thoughtful med rec, and then our cirrhotic management and our final intervention. We talked about which products to give for coagulopathy. So up there on the screen. We talked about interventions for cirrhotic patients. So reducing the acid, reducing their infections, and reducing their portal hypertension. And then lastly, we reviewed the diagnosis of hemorrhagic shock and how we don't wait for their hemoglobin to drop. We treat them empirically if they're in hemorrhagic shock. Questions on any of that? Okay, great job, guys. If you are looking for something to do, this is one of my favorite hikes in the area. It's Cheeseman Canyon. It is a pretty easy hike, pretty flat. You can make it as long or as short as you want. People are often fishing in the river. You can hang up a hammock, sort of hang out. It's about 45 minutes to an hour depending on traffic, but if you scan that, it'll take you to the All Trails link for it. And so maybe on your next day off, you want to go explore.
Please always give us recs.
Oh,
That's an
always,
amazing
yeah.
thing.
Any questions on what we talked about today?
Are these slides available, you said?
I can make them available. I will send you guys an email with a link to the YouTube channel for the other videos. And then I'll also put up these slides for you guys to access. Before